Good afternoon, students. I'm Dr. Orku. This is a rheumatology session of our pharmacotherapy class. So under this topic, we'll try to discuss the gout arthritis, osteoarthritis, and rheumatoid arthritis. So the first one is the gout. You are very familiar with gout. I think the Amharic equivalent word is the is inflammatory arthritis resulting from uric acid supersaturation and monosodium urate (MSU) crystal deposition in tissue. The macrophage phagocytosis of monosodium urate crystals and subsequent cytokine release lead to the formation of inflammation that results in gout. And unlike most of the rheumatologic problem, gout is more common in men as compared with female. So it's about 9-to-1 ratio, and the peak incidence is in about 5th decade. The most common cause of inflammatory arthritis in men over 30 years is supposed to be gout arthritis. It's rare in premenopausal women, as estrogen is supposed to be a preventive factor. Pseudogout is the form of gout with a deposition of CPP teeth. Clinical features: acute arthritis is a sudden onset, usually nocturnal or at night time, of painful monoarticular, with about 85 to 90% of the case, and it subsides in about 3 to 10 days. There is what we call podagra, is the deposition of these inflammatory cells at the METP or metatarsophalangeal joint of the great toe. So it will form swelling of the great toe. So if the patient comes with the complaint of swelling of the great toe, think of podagra, which is a hallmark of the gout arthritis. The precipitants for the gout arthritis, like rapid uric acid formation with the patient with increased dietary purine, in patient with surgery or infection, in patient using drugs like diuretics, particularly thiazide diuretics, dehydrated patients, and frequently hospitalized patients. In about 20% of the case, they will have gout. So these things will precipitate gout. This means any patient with this history who came with the swelling of the great toe or podagra, think of acute arthritis as a form of gout arthritis. Intercritical period is the remission of joint pain between attacks, and most patients suffer a second attack within 6 months to 2 years. So over time, attack recur at shorter intervals and lasts longer, and eventually resolves incompletely, evolving into chronic form of arthritis on which acute exacerbations are usually superimposed. When we take the radiography of this patient, we usually show only soft tissue swelling during the early episodes, but eventually the patient may enter a phase of chronic polyarticular gout with no pain-free interictal period, which we call it chronic tophaceous gout. Deforming arthritis from tophus formation causing pain and joint erosion, and at this stage, which is the final stage, gout may easily be confused with other type of arthritis or other condition. Tophi is deposition of urate crystal in the subcutaneous tissue and joints, commonly in the joints of fingers, wrists, knees, and on the ear, which on the deposition of on the ear, it's around the pinna. And tophi are really present at the time of initial attack of primary gout. The rate of formation of tophaceous deposit correlates with both the degree and duration of hyperuricemia. The process of tophaceous deposition advances gradually or incidentally, and although the tophi themselves are relatively painless, acute inflammation can occur around the tophi formation. Eventually, extensive destruction of the joints and the large subcutaneous tophi and progressive crippling will be formed. There is what we call triad of acute monoarticular arthritis, hyperuricemia, and the dramatic response to the colchicine is gout arthritis by default. If the acute monoarticular arthritis together with hyperuricemia, and if we put the patient on colchicine and if the patient respond, that arthritis is because of gouty arthritis. We can do tests in the patient who came with a complaint of arthritis. The best investigation is the arthrosynthesis. From arthrosynthesis, we will have polarized microscope, WBC, and we can also do radiograph. So in patient with gouty arthritis, increased uric acid does not make a diagnosis, because if you look only for increment of uric acid, we will miss about 75% of the patient, as 25% of the patient will be normal during acute attack, but they will have leukocytosis and increased erythrocyte sedimentation rate. This is the what you call tophi, deposition at the metatarsopharyngeal joints, and tophi at the pinna or ear area. Here again there is swelling, which is tophi. So management of gout, we have goals of management. The first one is to terminate the acute attack as promptly and as gently as possible, prevent recurrence of acute gouty arthritis, prevent or reverse complications of the disease in joints, skin, or other sites that occurred, prevent or reverse associated obesity, hypertriglycemia, and hypertension if there is any. So for acute treatment of gout, we usually start with the non-steroidal anti-inflammatory drugs. Drug of choice here is indomethacin, with a starting dose of about 25 to 50 milligram in TID based or QID based. But for using any non-steroidal anti-inflammatory drugs, you need to make sure that the patient has any renal problem, as these drugs are one of the drugs incriminated for renal failure. If the indomethacin is not available, we can use ibuprofen or diclofenac here. Colchicine is a drug that inhibits polymerizations of the microtubules that will prevent chemotaxis and phagocytosis that will result in depositions of the tophi. So if we prevent this by these drugs, we will prevent the depositions of the tophi. The other commonly medications are, or group of medications are corticosteroids or corticotropin. With particular example is prednisolone, with initial dose of about 20 to 60 milligram per day. These drugs are not the first to be used, but for highly recalcitrant case or resistant case, we can use steroids. But for initial treatment, the preferred one is non-steroidal anti-inflammatory drugs. This is a particular example, indomethacin. So before using any steroids, we need to rule out infection first. And timing of therapy initiation is more important than the choice of the drugs. Whichever the drugs, the earliest initiation is by far better. It says that the sooner the drug is started, the more rapidly a complete response will be attained, whichever the drug is used. Generally, colchicine is preferred for the patient in whom the diagnosis of gout is not confirmed yet, whereas non-steroidal anti-inflammatory drugs like indomethacin are preferred when the diagnosis of the gouty arthritis is secured. Prophylaxis, small daily dose of colchicine is about 85% of the time effective to prevent acute attacks. If the colchicine is not available, we can use again non-steroidal anti-inflammatory drugs. Maintenance dose of colchicine or any non-steroidal anti-inflammatory drug may take the difference between frequent incapacitation and uninterrupted daily activities. Prophylaxis continued until normal uric acid maintained and no acute attack for 3 to 6 months after initiation of the medication. And prophylactic treatment is not recommended unless urate-lowering agents are also used. Otherwise, the deposition continues without the warning signs of recurrent boost of acute arthritis that will finally result in chronic form of gouty arthritis. Chronic treatment with dietary purine restriction, especially diet with rich in protein, solely to control the serum urate levels, are rarely advised, because a total purine-free diet lowers urate level by 1 milligram per deciliter. Together with this, it's recommended to avoid dehydration and hyperuricemic drugs like thiazide diuretics. Anti-hyperuricemic treatment provide a definitive method for controlling hyperuricemia, and only long-term control of hyperuricemia modifies disease course. Once started, the treatment for anti-hyperuricemic is lifelong. And antihyperthermic treatment is indicated for frequent attack, tophi formation, nephrolithiasis or stone in the renal system, and nephropathy or renal disease of any cause. And the dose must suffice to maintain the target, which is about uric acid level of 5 to 6 milligram per deciliter. So till we have the uric acid level of 5 to 6 milligram per deciliter, we need to adjust the dose of anti-uricemic, hyperuricemic treatment. So any drug, for the treatment of anti-hyperuricemic or anti-hyperuricemia, do you know any drug that's used for treatment of hyperuricemia? So here are a group of drugs. The first one is xanthine oxidase inhibitor. This particular example is allopurinol and febuxostat. These are best used in over excretors or large amount of uric acid formation and patient with nephrolithiasis or stone patients. We can use allopurinol 100 milligram TID, but it will be insufficient in about 25 to 55% of the cases. Sudden decrement in urate may trigger acute attacks, and so it's recommended to start prophylaxis 2 weeks earlier or slowly titrate the dose of allopurinol. Uricosuric agents, which are a particular example is probenecid for under excretors. These are the drugs used for under excretors. Under excretors are individuals or patients whose urine output of uric acid is less than 600 milligram per 24 hours. The following should be avoided in any patient with hyperuricemia or gout arthritis. Try to avoid animal-based proteins like meats, beverage like alcohol, vegetables like peas should be avoided to have adequate response to our treatments. So this allopurinol can be used in overproducers, as we have said. It can also be used for undersecretors or patients with renal failure or kidney stone. Look, allopurinol is a drug which mechanism of action is xanthine oxidase inhibitor. So xanthine oxidase is the most rate-limiting enzyme for the formation of uric acid. So once we block the xanthine oxidase, so there will not be uric acid. That's why it is recommended as for overproducers, undersecretors, or for patients with renal failure or kidney stones. The other drugs, febuxostat, which is again another xanthine oxidase inhibitor, is recommended in patients who are intolerant for allopurinol. Pegloticase, it dissolves uric acid and recommended to be used in patients with refractory disease. Probenecid, like we have said, can be used in the undersecretors, which are about 80% of adult cases. Nowadays, it's rarely used because it's not as such user-friendly drug. As allopurinol is very available, we can use this drug rather than probenecid. The other topic is osteoarthritis, which is the disease of old age actually, a degenerative joint disease occurring primarily in all individuals, characterized by erosion of articular cartilage, hypertrophy of the bone as the margins, which we call it osteophytes, and subchondral sclerosis, considered by some results as a result of wear and tear, which is an inevitable consequence of aging. So osteoarthritis is an inevitable because as one ages, the risk of osteoarthritis seems imminent. It results in pain, deformity, and chronic disability. The risk factor top on the list is age, obesity, other like trauma, and being female is a risk factor for osteoarthritis. We have primary and secondary form of osteoarthritis. Primary means it is the commonest type, that is the cause is not known, but the secondary cause, the causes are metabolic, anatomical factors, trauma, or any inflammatory disorders like septic arthritis or ankylosing spondylitis can bring osteoarthritis. So the strongest association is with older age. The commonest chronic disease in later life, which is about greater than 80% of age is greater than 75%. Chondrocytes failure to maintain and repair the tissue because of aging. Women are about twice as likely as men to develop osteoarthritis, but beyond age 50 years, the risk will increase more. So there are early and late osteoarthritis. So in early, there is surface irregularity whereas in late osteoarthritis there is deepened clefts, increase in surface irregularity more, and eventual articular cartilage adhesion, and marginal osteophytes will be the late phase of osteoarthritis. Pain is the first pronounced symptom, typically affecting distal interphalangeal joint, and the most commonly affected joint is the knee joint, followed by hip joint. So it affects distal interphalangeal joint. It can affect multiple joints commonly with significant symmetric involvement. Stiffness in the morning that resolves in less than 10 minutes after inactivity, or particular in the evening. So the stiffness is in the morning or in the evening, but that resolves within less than 10 minutes. Knee giving way or locked knee is typical for osteoarthritis, and this is very devastating disease that will cause depression and daytime somnolence, because the patient will be disturbed to sleep at night time. Joint enlargement from joint fusion or bone swelling can be observed from X-ray, and there is also crepitus, which is audible or palpable sensation of crunching or crackling due to irregular cartilage surface or debris. Joint will be deformed. Joint exam can be normal in early phase of the disease, but as disease becomes advanced, there will be some abnormalities. Prognosis symptoms, but not radiographic change can improve. So radiographic deterioration observed in 30 to 60% of the patient, because as we have said, chondrocytes cannot balance the repair and the erosion. So we can reduce the pain, but we can't prevent the deterioration, as it has strong association with aging. This is the joint swelling as a knee side. This is what we call Heberden's node, which is the pathognomic for the osteoarthritis. It just affects DIP, distal interphalangeal joints. Management, so targets pain relief mostly by using the drug of choice is non-steroidal anti-inflammatory drugs. We can use them topical or systemic. We can also use paracetamol, tramadol, cocaine, and if the depression occurs, we can use tricyclic antidepressant. Do you know any drugs that's classified as tricyclic antidepressant? Yes, amitriptyline, imipramine. We can also use SSRI or selective serotonin uptake inhibitors like fluoxetine and paroxetine for the depression following osteoarthritis. There is no role for systemic corticosteroids in osteoarthritis. Don't use systemic corticosteroids in patients with osteoarthritis. No role at all. But local intra-articular corticosteroid injection can be effective, especially if used less than 4 times per year, as they have a side effect. Don't use them for long period of time. Other options like intra-articular hyaluronic acid can be used. Glucosamine, chondroitin sulfate can be used for osteoarthritis. But if there is no response with the non-steroidal anti-inflammatory drugs, with the opioids, with the intra-articular injection and the likes, there is a place for surgery. We can do osteotomies or joint replacement. So this is a graphic representation of the summary of diagnosis and management of osteoarthritis. Look, we need to confirm the diagnosis. After that, there will be patient education, psychosocial issues should be addressed. So consider topical agents like capsaicin, non-pharmacological modalities like weight loss, exercise should be advised. If there is significant inflammatory component, look whether there is significant inflammatory component or not. If there is, so try with non-steroidal anti-inflammatory drugs. If there is no inflammatory process, try it with acetaminophen, which is paracetamol. If there is inflammatory, one option is to use non-steroidal anti-inflammatory drugs or COX-2, or if single joint is involved, we can try with intra-articular corticosteroid infiltration. Again, if the pain is persisted, we can try with the opioids, narcotic analgesic like pethidine or codeine. If again there is no improvement, we can do surgery. So this is the graphic summary of the diagnosis and the management of corticosteroids, the osteoarthritis. Sorry. Here again the same principle. Use non-pharmacological treatment like exercise or weight loss. Then symptom persist, try with non-steroidal anti-inflammatory drug, PRN based. If symptom persist, we can use topical non-steroidal anti-inflammatory drug, calcium. Again, symptom persist, use intraarticular glucocorticoids or intraarticular hyaluronic acid. If symptom persist with significant impairment, there is a place for surgery. So this is a very important summary of management of patient with osteoarthritis. This is a case scenario. A 32-year-old nurse presents with intermittent episodes of pain and stiffness and swelling in both hands and wrist for approximately 1 year. The episode lasts for several weeks and then resolves. More recently, she noticed similar symptoms in her knees and ankles. The joint stiffness usually lasts for several hours before improving. Physical examination reveals a well-developed woman. The joint examination reveals bilateral swelling, redness, and the tenderness of most proximal interphalangeal joint and metacarpophalangeal joints, wrist and the knees. Laboratory showed mild anemia with hemoglobin of 11.2, with MCV 85.7, and the ESR or erythrocyte sedimentation rate is 75 millimeter per hour. So what is your most likely diagnosis? Is it gout arthritis? Is it osteoarthritis, or is it rheumatoid arthritis? It is a case of rheumatoid arthritis, but what are the clues that indicate it is rheumatoid arthritis? What is your next diagnostic step? And what drug constitutes the cornerstone for the management of the above case, meaning the cornerstone for the management of rheumatoid arthritis? So take this as brainstorming, and we'll discuss rheumatoid arthritis. Then you will come back to the case scenario. Okay, so rheumatoid arthritis is a chronic, symmetric, destructive autoimmune polyarthritis caused by inflammatory proliferative synovial tissue or PANAS formation, and increased with shared epitope on class 2 MCH, DRB1 and DR4, and high risk with shared epitope and smoke and gene environmental interaction with like there is a gene and environmental interaction, especially cigarette smoking is has a risk for the development of rheumatoid arthritis. Again, it is more common in female, onset about age 35 to 50 years, and if there is a family history, the risk is about 10 times. So synovial inflammation and the proliferation, focal bone erosion, thinning of arterial cartilage, there will be pain, swelling, and impaired function of joint, typically the PIP, proximal interphalangeal joint, not distal here. Metacarpophalangeal joint will be affected. So I think you notice there's a difference between rheumatoid arthritis and osteoarthritis. Osteoarthritis affects which joint? DIP, distal interphalangeal joint, whereas rheumatoid arthritis affects PIP, proximal interphalangeal joints. There is what you call morning stiffness or gel phenomena, and polyarticular, or it is oligoarticular in about 75% of the case, usually small joints, but can affect large joints. In about 10% of the case, it can involve both small and large joints. Undifferentiated inflammatory arthritis, we call them rheumatoid arthritis prodrome. So here the arthritis is with joint immobilization, muscle shortening, bone and cartilage destruction, and joint deformities with ulnar division, what you call them swan neck, boutonniere, and the cock up deformities are typical for rheumatoid arthritis. I will show you swan neck and boutonniere deformity later on in the next slide. There is also myelopathy with C1, C2 instability. So any patient with risk that complains the neck pain and the legs, think of myelopathy following rheumatoid arthritis. Rheumatoid nodules, which is typical in about 20 to 30% of the case, usually in seropositive, with patient with rheumatoid factor positive, or extensor surface along the tendon sheath. And this rheumatoid arthritis is actually, even though it affects the joint mostly, it is a systemic disease that manifests with fever, weight loss, and malaise. It can affect the eye, which presents with scleritis, the keratoconjunctivitis sicca, or Sjogren's syndrome, with dryness of the eye. It can affect the lung, so pulmonary manifestation about 20% of the time precedes the joint manifestation. The typical pulmonary manifestation of rheumatoid arthritis are interstitial lung disease (ILD), pulmonary hypertension, pleural effusion, which manifested with decreased pleural glucose, and cricoarthroid arthritis are typical manifestations of rheumatoid arthritis on the lung. This is a pulmonary deformity. It affects the proximal interpharyngeal joint. Here is the ulnar division of the hand, and here is the swan neck. You know swan? It just seems the swan neck. Swan is, I think, one of the birds. So this is the deformity. If you find the patient with this deformity, this is typically rheumatoid arthritis. But if had it been osteoarthritis, it usually affects the distal interpharyngeal joints. Typical for osteoarthritis. Swan neck, here is the proximal one. Boutonniere, Heberdennus, which is distal interpharyngeal joint, typical for the osteoarthritis. Again, Bouchard's node is another typical manifestations of osteoarthritis. So Heberdennus node and the Bouchard's node for osteoarthritis, whereas swan neck deformity and the boutonniere deformity is for rheumatoid arthritis. What is this? Yes, what does it look like? Prayer sand. Prayer sand is typical for diabetes mellitus, chronic liver disease, and the legs. You can read prayer sand with its differential diagnosis. So this is the tabular comparisons of rheumatoid arthritis with osteoarthritis. Almost we have discussed, but the typical one, age, this is a young age, this one is for old age. Early symptoms, there is what called morning stiffness, but in osteoarthritis, pain increases through the day and with use. But in rheumatoid arthritis, the pain is at the rest or morning stiffness. The joint, typically rheumatoid arthritis affect PIP and metacarpopharyngeal joints, but almost never affect DIP. But in case of osteoarthritis, it is distal interpharyngeal joint. Students, knowing the difference between rheumatoid arthritis and osteoarthritis is very important because the management is totally different. So you can read the graph. This is the table. So management of rheumatoid arthritis. Once we diagnose the patient with rheumatoid arthritis, what are our managements? So we have goals of management. The first one is early aggressive therapy. Once we diagnose rheumatoid arthritis, we need early and aggressive therapy. Frequent modification of therapy is needed based on the response, individualizations of therapy, and achievement of remission. Components, we have a group of drugs like non-steroidal anti-inflammatory drugs, glucocorticoids, DMARDs, disease-modifying anti-rheumatoid drugs. Very important. These are the cornerstone of management of rheumatoid arthritis, DMARDs. And physical therapy and assertive device if the patient is not responsive to the medical one. So DMARDs are disease-modifying anti-rheumatic drugs, as they will slow or prevent structural progression. Start DMARD treatment early, what we call window of opportunity. The sooner is better. Multiple approaches to therapy. The first one is step-up sequential monotherapy, like we can start with a single monotherapy, then escalate the drug based on the response. The second approach is step-up combination approach. Example, triple therapy with the combinations of the DMARDs like methotrexate, sulfasalazine, and hydroxychloroquine. In fact, this drug is a drug that's supposed to be the game changer for the management of COVID-19, but unfortunately, it's failed to show any benefit. Rather, it showed the more days among the patients who took the hydroxychloroquine for the management of COVID. So, hydroxychloroquine is a drug for the rheumatoid arthritis, not for COVID. So triple therapy is more effective than methotrexate alone. The third approach is step down bridge approach, which is initial with prednisolone, then combination of DMARS taper to monotherapy. This is the best, by the way. Step down bridge approach. Initially start with steroid or non-steroid anti-inflammatory drugs, then combination of DMARS, which is later on taper to monotherapy. So the bridge approach is the best one. So the commonly used drug for rheumatoid arthritis is MTX, that is methotrexate. This is a fast clinical resolution and slow structural damage to the cartilage and the joint. It has toxicity actually at the GI, liver, renal, pulmonary. It has side effects. Actually, the drug is actually these drugs are the many medical usage, but will not go detail of the medical use. But we will only focus on use of methotrexate in rheumatoid arthritis. If you are interested, you can read the use of methotrexate in other diseases. So well tolerated, with more patients like to be taking methotrexate 2 to 5 years after it's first prescribed, and dose can be escalated over time from initial 7.5 milligram once weekly to more than 25 milligram weekly. And rapid dose escalation from over 8 weeks has become the standard regimen in the management of rheumatoid arthritis. Whenever you treat the patient with methotrexate, you are expected to add folic acid to reduce the nausea and mucous membrane ulceration, and also for the prevention of bone marrow separation. That is 5 milligram folic acid once weekly or 1 milligram daily. Adjunctive drug treatment, that is the breakthrough, or what you call step down bridge approach. We can use glucocorticoids as adjunctive drug for the management of rheumatoid arthritis, the fastest and the most effective and immediate symptomatic relief. And rheumatoid arthritis disability versus glucocorticoid symptom relief or activity has shown to be improved if the patient is on adjunctive drug therapy. Low dose daily glucocorticoid reduce the rate of radiographic progression, and higher cumulative toxicity and twofold increase in mortality. Actually, there is the mortality if you use the steroids, but as compared to the rheumatoid arthritis disability, these drugs are beneficial. But in terms of mortality, there is cumulative effect that will increase the mortality. So target to control the disease within 6 months, like glucocorticoids are no longer needed and can be slowly tapered and shifted to the monotherapy with methotrexate. Low dose PO glucocorticoids for short period as adjunct to DMARD is justified. Early disease, refractory disease, and pregnancy. In such type, we will recommend low dose PO glucocorticoids for short period. The dose can be, the drugs can be given in PO or IM or intraarticular routes. Adjunctive drugs treatment can use again non-steroidal anti-inflammatory drugs. The most often used very effective adjunctive therapy as compared to the steroids. So we have two groups: non-selective and selective non-steroidal anti-inflammatory drugs. So selective COX inhibitors are they have low risk of GI bleeding and platelet dysfunction, similar nephrotoxicity and hypertension with non-selective one, and they have increased risk of cardiovascular disease. So the drawback of these selective COX inhibitors, they increase the cardiac morbidity. Otherwise, fewer GI bleeding and platelet dysfunction, almost comparable nephrotoxicity and hypertension with non-selective one. Any examples of drug from selective COX inhibitors? Celecoxib is selective one. Most of them have cardiovascular side effects. That's why they are not available as such. We can also use paracetamol for adjunctive drug for rheumatoid arthritis treatment with methotrexate. So here is a graphic illustration of the management of rheumatoid arthritis. establish the diagnosis of rheumatoid arthritis early, document baseline disease activity and damage, estimate the prognosis, then initiate therapy. Like, in fact, one of the therapies, patient education, started DMARDs within 3 months of the diagnosis, consider non-steroidal anti-inflammatory drugs as adjunctive, consider local or low-dose systemic steroids, physical therapy or occupational therapy, and this can be done by primary physician or any health officer or any health professional at the primary care. Then we can refer the patient with rheumatoid arthritis to the rheumatologist or internist, which will further assess the patient's the level of disease and adjust these drugs, dose and the likes. These are the DMARDs, examples of drugs: hydroxychloroquine, as we have said, sulfasalazine, methotrexate, leflunomide, minocycline, gold salts, penicillamine, azathioprine, cyclosporine, and biological DMARDs like tumor necrosis factor inhibitors like infliximab and etanercept, rituximab, and Ankara are drugs shown to be effective for the management of rheumatoid arthritis based on the level of the disease progression. The tumor necrosis factor, you can read this: infliximab, adalimumab, etanercept, but these are not as such available in our cases, but they are one of the group of DMARDs. So here is the best summary. We first establish the diagnosis of rheumatoid arthritis, initiate methotrexate at least within 3 months of the diagnosis. If the methotrexate is not available, you can start with steroids or non-steroidal anti-inflammatory drugs. Then if the symptom persists for greater than 6 months, that is step-up therapy, like add biological agent like tumor necrosis factor inhibitor like infliximab, whichever is available. Parallel therapy, you can add another non-biological agent like sulfasalazine or hydroxychloroquine. If on top of methotrexate we add sulfasalazine and hydroxychloroquine, we call it triple therapy. If the response is inadequate, again after initiation of this biological group, we can consider surgery, and we can again switch to alternate TNF inhibitor and continue with methotrexate. TNF alternative, if we start with infliximab, we can change it into adalimumab. If adalimumab is again ineffective, we can change it to etanercept. In fact, all this should be combined with methotrexate, but if the response is not as such rewarding, there is a place for surgery and the likes. Actually, surgery is not as such recommended in patients with the rheumatoid arthritis, as the disease is a very systemic disease. We can say surgery has no role. But in case of osteoarthritis, if the patient is resistant to medical therapy, there is a place for surgery. But here, surgery is not recommended for the management of rheumatoid arthritis. We can just exchange group of drugs. If we start with methotrexate and add on sulfasalazine, hydroxychloroquine, we can change it to tumor necrosis factor inhibitor. We have different form of tumor necrosis factor. Then we can just exchange them between them, among them. This is the table summarizing the management of mechanism of actions of DMARDs with their typical adverse effect. Methotrexate, as you know, it is purine antimetabolite. The side effect is hepatotoxicity, stomatitis, which is the ulceration of the mouth, cytopenias, that's effect on the bone marrow. Leflunomide, it is pyrimidine synthase inhibitors. It is known for its hepatotoxicity and cytopenias. Hydroxychloroquine, which is a tumor necrosis factor and interleukin-1 suppressor. The typical adverse effect or pathognomic one is retinopathy. So you need to check eye every 3 months for patient whom started on hydroxychloroquine for the management of rheumatoid arthritis. Sulfasalazine, it is again the tumor necrosis factor and the interleukin-1 suppressor. The typical side effects are hepatotoxicity, stomatitis, and hemolytic anemia. Tumor necrosis factor inhibitors like adalimumab, certolizumab, etanercept, golimumab, and infliximab, they are immune suppressive drugs, so they will predispose the patient to infection and the more opportunistic infections, for congestive heart failure, and even for some of the malignancies and the demyelination are adverse effect of these tumor necrosis factor inhibitors or biological factors. So if you start the patient on those drugs, you need to evaluate the patient for any infection. So thank you for your attention. I hope you will read through the slides. We will go through the slides, and if you have any question or suggestion or comments, please forward me through the Telegram or email, and I will respond on time. Thank you very much.